Welcome. In this video, we'll break down the major causes of an elevated erythrocyte sedimentation rate, or ESR, and guide you through a practical step-by-step approach to workup, all based on clinical context. Let's get started. ESR is a nonspecific marker of inflammation, and it can be elevated for a wide variety of reasons. We'll organize the causes into 6 main categories. First up, inflammatory and autoimmune diseases. These are some of the most common causes of elevated ESR in clinical practice. Rheumatoid arthritis, systemic lupus erythematosus, polymyalgia rheumatica, giant cell arteritis, vasculitis such as granulomatosis with polyangiitis, inflammatory bowel disease, ankylosing spondylitis, Sjogren's syndrome, systemic sclerosis, coidosis, Still's disease, Behçet's disease. Infectious causes can be either acute or chronic. Think of ESR as a chronicity marker. It rises gradually and can stay elevated. Tuberculosis, bacterial endocarditis, myelitis, abscesses, TIs, pneumonia, fungal infections, HIV, syphilis, viral infections like EBV, CMV, or hepatitis viruses, malignancies, especially those involving the bone marrow or lymphatic system, can elevate ESR significantly. Hodgkin and non-Hodgkin lymphoma, multiple myeloma, leukemia, solid tumors with metastasis, renal cell carcinoma, chronic kidney and liver diseases can also cause elevated ESR, particularly when associated with protein abnormalities or inflammation. Chronic kidney disease, nephrotic syndrome, end-stage renal disease, hepatitis B or C. Don't forget the miscellaneous category. These conditions may not always be top of mind, but they're important to consider. Anemia, obesity, pregnancy, aging, diabetes mellitus, hyperlipidemia, recent surgery or trauma, tissue infarction, cryoglobulinemia, and a few medications can also lead to elevated ESR. Oral contraceptives, methyldopa, vitamin A, theophylline. Now let's talk workup. This is always guided by your patient's history, symptoms, and exam findings. But here's a structured framework to get you started. Start with a basic inflammatory and metabolic panel, CBC with differential, comprehensive metabolic panel, CRP. Next, consider autoimmune serologies, ANA, rheumatoid factor, anti-ANCA, DNA, C3 and C4, SSA, SSB. HLA-B27. Then assess for infections, blood cultures, hepatitis panel, testing, syphilis serologies to evaluate for malignancy, serum protein electrophoresis, LDH, peripheral smear, and possibly bone marrow biopsy. Add specialty labs as needed. Cryoglobulins, ferritin and iron studies, P ratio. Use imaging to target suspected organ involvement. Chest X-ray or CT, cardiogram, abdominal ultrasound or CT, for sarcoidosis, ACE, calcium, ophthalmologic exam, tissue biopsy. To sum up, ESR is a helpful clue but always requires clinical context. A systematic approach can help differentiate between autoimmune disease, infection, malignancy, or other causes. Thanks for watching and stay tuned for more practical rheumatology insights.